Hello, everyone. Thank you so much for joining us today. Thank you so much for joining us today for today's program, All in the Family Update on Hereditary Neuropathies and Treatments, presented by us here at the Foundation for Peripheral Neuropathy. I'd also like to give a huge shout out to Alnylam Pharmaceuticals, who is sponsoring this webinar. We're incredibly grateful for their partnership and support for our educational program. Thank you, Alnylam. I'm Amanda Homscheid, Program Manager at the Foundation for Peripheral Neuropathy. On behalf of our team, board members, and volunteers, thank you for joining us and for trusting us to be part of your journey as you navigate living with peripheral neuropathy. Before we begin today's program, I want to go over a few logistical items with you guys. The first thing that you may have noticed if you've already attended some of our webinars before is that this one looks a little bit different than what you're used to. I'm happy to welcome you to our first webinar of 2026 that is through our new webinar platform On24. We are incredibly excited about this upgrade, and I'd like to kind of show you around a bit so you're able to see and access it all that it offers. So where I'm speaking from right now, which is the media player, you can turn on closed captioning here. If you hover over it and click on the gear, you can turn on closed captioning. You also have the slides, which are in the middle, which you're seeing right now. Those should be the biggest in the middle. You can make me the speaker, media player, and the slides in the middle. You can make those bigger or maximize them or leave them the same. Then over to the right-hand side, I want to show you up at the top. You should see the question box. That's that blank box above the Donate Now button. But you'll also see above that you have some other options. So the first one, you've got Ask a Question. That is already on there. That is the same type of question you were used to if you went to a previous webinar. We will use questions from there that are asked during the live programming and questions that were submitted at registration during our live Q&A at the end of the presentation. Then you can also see some of the additional resources that we have. Additional resources is the first one. You can click and download today's slides if you would like. You also can learn more about the wonderful speakers that I'm going to introduce you to in a moment. And then you can see a survey that we are going to ask you to take either during the programming or at the end. And then last but not least, you have the reactions that you can choose, and some of you have already used, which is great, to give our presenters some live feedback during their presentation. Last thing I want to mention before I introduce our speakers is that we are still recording today's live program. It will be emailed to all registrants within 24 hours following the end of the program. It'll also be put on our website by the end of today, along with the presenter slide deck if needed. And now I'm incredibly pleased to welcome and introduce our experts today. First, we have Dr. Peltier. She's an associate professor at Vanderbilt University Medical Center, where she serves as the fellowship director for the neuromuscular program. She's also an active member of the Vanderbilt Autonomic Disorders Center and the Vanderbilt Amyloid Multidisciplinary Program. Dr. Peltier earned her medical degree from the Ohio State University before completing her neurology residency at the University of Michigan. She pursued advanced training with a neuromuscular fellowship where she gained expertise in EMG, skin biopsy techniques, and autonomic testing. Completing her clinical focus, Dr. Peltier holds a master's degree in clinical research design and statistical analysis. This enables her to lead groundbreaking research initiatives. So we're welcoming Dr. Peltier. Next, we have Sean. Sean lives in New Hampshire and is a retired nuclear reactor operations training instructor and also a professor of nuclear engineering technology. He was diagnosed with the T80 variant of hereditary amyloidosis in March of 2019 and immediately began treatment. Sean volunteers as a speaker for the Amyloidosis Speakers Bureau, a nonprofit organization whose mission is to help educate the medical community so that future patients can be successfully diagnosed and treated at a much earlier stage of disease progression than he was. Sean is retired and enjoys spending his time with his amazing wife, Robin, cooking, drawing, and tending to their two Great Pyrenees dogs, Cassie and Julia, and their little cat, Lila. We are extremely lucky to have both Dr. Peltier and Sean here to speak on this topic. And with that, I'm very excited to pass this virtual mic over to you, Dr. Peltier. Thank you again.
Thank you so much, Amanda. I'm going to get started, and I have a lot to cover. And I realized that I didn't include my disclosures, so just FYI, I have actually worked with 2 of the companies that provide treatments for patients with amyloidosis, Alnylam, who's sponsoring this, and AstraZeneca. And given talks for both of companies and done research with both companies. So with that, I will get started. I also realized that I forgot to give kind of a goals for today. So initially, I'm just going to talk in broad strokes about peripheral neuropathy, types of nerve fibers, and kind of what does that mean as far as like you as a patient and then us as doctors, and like what symptoms you might have depending on what type of neuropathy you have, and then talk more specifically about inherited neuropathies, and then talk even more specifically about hereditary amyloid neuropathy. And so just with that, I will talk about nerve fibers. So we group nerve fibers into what they do and kind of the information they carry. So motor nerve fibers have big sheets of myelin that wrap around them, and that myelin is made by another kind of cell called the Schwann cell. And that allows those fibers to transmit information super fast, which is important for especially for motor fibers. And and then also those fibers also show up on EMG or nerve conduction studies when they use electricity to test the nerves, and that's will be important later on when I talk. And then so obviously when those motor nerves are affected, that causes weakness and atrophy of the muscles. The sensory fibers are divided into 2 types of fibers. So again, myelinated fibers that have big sheets of myelin that wrap around them that tell you kind of where you are in space, allow you to, for example, stand up, close your eyes, and not fall over. And then small fibers that don't have myelin around them that convey like light touch, pain, and temperature. And those fibers don't get picked up by a nerve conduction study test well, and often cause a lot of pain, sometimes not. And then the autonomic fibers are also fibers that don't have myelin around them. And so when we talk about large and small, you're literally talking about the diameter of the fiber. But those autonomic fibers go to all your other organs, basically, you know, innervate the heart. They tell the heart how fast to beat, go to the blood vessels, tell the blood vessels how much to constrict, that help control your blood pressure, controls your bladder, controls sexual organs, controls your GI tract. And so that will be pertinent as we go on. And then this is just kind of a schema of all those fibers. Now, all the things I'm talking about today are all in what we call the peripheral nervous system. So basically, once you exit the spinal cord, that all those nerves are the peripheral nervous system. And we're not going to talk so much about muscle themselves or spinal cord involvement or brain involvement, but that can be affected in certain diseases. So inherited neuropathies are neuropathies that are caused by a single gene mutation or a gene deletion where part of the gene is missing, or when a gene gets duplicated. So like, for example, when your cells are copying themselves to make eggs, sperm, etc., and they make too many extra copies that go into that chromosome, that can mess up gene function as well. And we think that they count for about 7% of all neuropathies. So by far not the most common type of neuropathy. In the United States, the most common type of neuropathy is actually diabetes. But it is not uncommon. And of course, as we do more genetic testing, we find out more and more people may have these mutations. And then, of course, these neuropathies can be motor-only neuropathies, sensory and motor, sensory and autonomic, or sensory, motor, and autonomic. So all those different combinations kind of help us as doctors figure out which gene defect is the most likely. And because inherited neuropathies were originally described by a couple of doctors named one, Jean Charcot, and his pupil, Dr. Marie, And then another doctor in England, Dr. Tooth, that's how it got its name, Charcot-Marie-Tooth disease, which is a little atypical since we've kind of moved on from naming disorders after doctors anymore. And this was back in the 1800s, whereas hereditary amyloidosis was not actually described until 1952 in Portugal. And of course, we've subsequently found that particular inherited disorder, amyloidosis, affects about 50,000 people worldwide, so a very small percentage if you think about it compared to all inherited neuropathies. Now, Charcot-Marie-Tooth or hereditary sensory-motor neuropathy, often you'll have a family history. Like I have multiple family members where I'll see grandparent, parent, child. And the most common forms are what we call autosomal dominant, meaning you only need one gene to be abnormal. So basically you have a 50-50 chance of getting it. So there's usually a family history in that case. It typically affects the ends of the nerves first because they're the farthest from the cell body. So there's a long, your nerve cells are the biggest cells in your body, because if you think about how long it takes to get from your mid back, for example, to the tips of your toes, that's a long distance for a single cell to stretch. And you have to move information back and forth up that whole length of nerve. So that's why the ends of the nerves are the most fragile. So that's why people typically start noticing changes in their feet first, and then changes as they move up their legs, and then get atrophy in their calves. And pes cavus is when your arches get super high, and then hammer toes because of the imbalance at which muscles get atrophied. So like the toes start going up like this. And a lot of times if you do what's called a lumbar puncture or spinal tap, you'll see like high protein in the spinal fluid from just those nerves just not working well, and basically sloughing off a lot of protein in the spinal fluid. And the reason why I mention that is because a lot of inherited diseases will do that, and then we also see that in autoimmune diseases. So when you see that, it's not always very specific, unfortunately. So like I said, you can inherit diseases either dominantly, meaning you get a 50-50 chance, or recessive, meaning that unless your parents are related, generally you might have siblings with the disease, but you're not going to have other family members with the disease typically. Or an X-linked gene is where, because men don't have another X copy, they're more likely to have more severe features compared to women with the same gene disorder. And if you look at all the most common genes, the most common one is what we call CMT1A, which is when the PMP22 gene has a duplication where there's more than one copy. And that's the most classic one that covers for most of them. And you see like amyloid is very, very tiny. You can't even see it on the screen. And then, like I said, now when we started describing neuropathies, we described them both by how they look in the lab with nerve connection studies. Can you detect it on a nerve connection study or not? And also how they were passed on. So CMT1 is autosomal dominant and affects myelin, so they're very slow. So when you do a nerve study, like typically your nerves are speeding along at about 45 meters per second. That's how fast it takes from, for a nerve impulse to travel in most nerves. But in those patients, it's more like 15 or 10 meters per second. So really, really slow. And then CMT2 is what we call axonal diseases, where it's affecting the actual axon, the actual nerve fiber, not so much the myelin. And then CMT4 were diseases that affected, that were recessive and were not dominant. Now you notice CMT3 is missing, and that's because when we started doing genetics, we realized that CMT3 were the exact same thing as CMT1, but for whatever reason, just showed up when people were babies as opposed to when they were teenagers or older adults. And then, of course, there are X-linked disorders, there are CMTX, and then we get down to the sensory and autonomic neuropathies that are incredibly rare. Then you get down to hereditary amyloidosis, which is even which is probably more common than the hereditary sensory and autonomic neuropathies. Now, switching gears to amyloid, amyloid itself, there's multiple proteins that we group together called amyloid. So you probably heard about amyloid in Alzheimer's disease and amyloid and other things. And really what amyloid just refers to is that proteins that are in a certain conformation that look pink on certain stains when you look at it in tissue, and they show up as green when you look at it under polarized light. And the key thing about that is that cells have a really hard time getting rid of that tissue, so it causes a lot of problems in the cells that amyloid protein gets stuck in. And there's multiple types of amyloid. The most common, actually, that affects nerves is what's called light chain or AL amyloid. And a lot of you are probably tested for AL. I don't know, Sean, if you were tested for AL with serum protein electrophoresis or bone marrow biopsy, but some of our patients have had to go through that.
Yeah, so in my case, yeah, so they had to differentiate to see if I had light chain or hereditary amyloidosis. So they do the blood work to make that differentiation.
Yeah, so so that's very common. Now, the transthyretin gene that is the culprit in the most common type of hereditary amyloid. There are a couple other ones that are even more rare. There's over 160 mutations, and it used to be that we would say, oh, some of them are more neurologic, meaning they affected neuropathy more, caused more neuropathy, and some of them were, quote, more cardiac, meaning that they affected more cardiac heart function more. And now I'm using the old genetic kind of nomenclature because a couple of years ago, geneticists decided that they should recount where they start in that particular gene. So now it's like V142I, T80A. So that sometimes gets confusing for patients, like, well, what is it? It's basically the same thing. We just, and so some of us flip-flop. But anyway, but really, as we get more and more data on all these patients, we find that really probably all patients have some degree of nerve and heart disease. It's just a matter of sometimes who do they see and what test do they get and how hard do we look to know whether or not both types of cells are affected. And transthyretin itself, and the reason why I'm going to go over this is because it's important for treatment later on, is that it exists as 4 peptides stuck together, and the name actually says exactly what it does. So it transports thyroid hormone and retin, which is vitamin A, around in your body. Now, obviously, other proteins can do the same function, which is important because one of the treatments is to actually just not make the protein. But what happens is that those 4 peptides stop sticking together, then they fall apart, and then they start getting into this different conformation that the cells can't get rid of and they just can't process. Now, some people will have an inherited mutation that makes it more likely for that to happen. Some people don't. And so people have what's called wild type amyloid, where they can have heart disease, they can have carpal tunnel, they can have other problems, but they don't actually have a mutation. And there's a lot of similarities between light chain amyloid and hereditary amyloid, which is what makes it tough sometimes, and why a lot of people end up going through both looking for both. But one of the big differences between the two of them is because TTR likes to go to ligaments and tendons, not only is it more common to affect the carpal tunnel because your poor median nerve is in the center of your wrist with a bunch of tendons and ligaments surrounding it, but it also tends to go to spinal cord ligaments, so people get spinal stenosis. It tends to it can cause muscle tendon ruptures, and then it also gets made in the eyes and in the lining of the brain called the meninges. And so some people can get strokes and problems with their eyes, and you don't see this particular thing in all patients, and you don't see it in AL patients typically. But the things that they all do is they all cause neuropathy. They can all have the potential to cause heart problems, and especially GI problems. So not only does it actually affect those autonomic nerves going to the gut, but it actually is in the gut itself, which is why some people get biopsies of their rectum. But also it can cause diarrhea, constipation, bloating, and it's really common. It's probably one of the biggest things that most patients complain about is their GI symptoms, and that can sometimes be worse than the actual regular neuropathy. And then the carpal tunnel usually happens years before people start developing neuropathy or heart disease, and we're using V122I or V142I in this example because in the United States that is the most common mutation, but around the world V30M is by far the most common. But all of them, the carpal tunnel tends to happen a lot earlier than anything else. And when we looked at a bunch of patients in at Vanderbilt and all at Charlotte, North Carolina with my colleague Irvi Desai, and in Philadelphia, Pennsylvania with my colleague Ristalina Ilyeva, what we found is that almost everybody had carpal tunnel, and a lot of times people had carpal tunnel in both hands or in their non-dominant hands. So I'm actually left-handed, so that's why I'm actually holding up my right, which you're like, well, wait a minute. As opposed to most people who get carpal tunnel because of what they're doing or like they're diabetic or whatever, most people get carpal tunnel in their dominant hand. And that still happens, obviously, but in this disease, it's more likely to be the opposite. And then they can have all sorts of different types of neuropathy. And that makes it really hard for us as neurologists to figure out what's amyloid, because it can look like a demyelinating neuropathy, can look like an inherited neuropathy, it can look like a small fiber neuropathy, because all those different types of nerve fibers are affected. So that makes it challenging for us. And then the way you make the diagnosis is by having a genetic mutation, having a pattern of neuropathy, or seeing the actual amyloid in the muscle, in the heart, in the kidneys. But when it comes to peripheral nerves, unfortunately, biopsies aren't always as good. So sometimes the chance of finding it on a nerve biopsy is 50-50. And if you think about it, it makes sense. When you do a heart biopsy, you get the whole cell in your biopsy. When you do a nerve biopsy, you're getting a segment about this long of a nerve that's like, you know, in your leg, for example, if you do a sural nerve, that nerve is well over 2 feet long, depending on how tall you are. So you have if you're lucky, you find it, and if you're not lucky, you may not. Now, some people are now doing skin biopsies and looking for amyloid in the skin, but unfortunately, that really depends on the mutation. So some mutations, you can pick it up in the skin, and some you can't. So that makes it tough, on our end as well. But like I said, this is a worldwide disorder. So you can see amyloid all over the world in every country pretty much. And it's interesting because in different countries or different areas where you have different mutations, you'll see different things. So some countries, like I found out at a meeting that Chinese patients, they have a mutation where it can affect their eyes very early in the course of the disease, whereas we almost never see that in the United States. Where people have actually like amyloid in the eyes causing cloudy vision. And then in other countries, it can affect it can cause happen really young, like in their 30s and 40s, whereas in some countries you can have the exact same mutation and it can start in their 60s. And people can have more weakness, less weakness. So it's really fascinating as a neurologist, how it can look so different with the exact same gene all over the world. And it obviously tells us there's a lot other genes that are impacting that function and how that looks. And so because of that, though, when we looked at treatments, a lot of the treatments were first looked at in neuropathy because worldwide, that is the biggest issue. And obviously, the United States is a little different because in the United States, the most common mutation was V122I or 142I that And cardiologists didn't always notice the nerve involvement. And so for a long time, it was thought that only maybe a third of those patients had nerve involvement, whereas in V30M, which is by far the most common and accounts for, as you can see here, like almost all of the, a good portion of the rest of the world. And that was what was originally described in Portugal. Those patients start out with a neuropathy that gets really progressive over time with really bad GI symptoms. So that's why they focused on the nerves first. And so one of the big groundbreaking things that happened is that we had what we call stabilizers around, where tafamidis, which is now prepackaged as Vindamax by Pfizer, and what it does is it keeps those 4 peptides together so they don't fall apart and get stuck other places. But the next big step in treatment was the gene silencer. So patisiran, which was one of the first molecules made by Alnylam, and then inotersen, which was made by Ionis. They both do the same thing, although slightly differently. So patisiran and all of the ones made by Alnylam are what we call small interfering RNA molecules, whereas inotersen and then the next generation eplontersen, which is what's available today, are what we call oligosense DNA nucleotides. But what they do is they basically attach to the messenger RNA in the cell, and they basically stop you from making any TTR. So your TTR levels go way down, and the way you know that is, one is if you were to check a vitamin A level, it'll come back as almost undetectable if you're on what we call one of these gene silencers. And then also your prealbumin level will also be very low as well. But what you see is that when they looked at patients, so they used a couple of different ways to measure the neuropathy, called the neuropathy impairment score, or a quality of life score called the Norfolk quality of life score. And this is just showing the protein levels being super low. And these are basically similar scores. What we found is that the people who didn't get medication just kept getting worse and worse and worse, whereas the people who did get mutation leveled out or got even actually a little bit of improvement. And so, so that was a huge, huge game changer in the course of this disease. And still probably for neuropathy, they're the most common ones used. And vutrisiran, which is kind of the second generation molecule that became an injectable molecule as opposed to having to get an infusion, that was tested in the heart by Alnylam and then had showed that like tafamidis, it really minimized people going into the hospital or people having follow-up problems for the heart from the heart failure. And they're in the process of studying the same thing with eplontersen, and we expect that data to be out this coming year, but that trial started a little bit later. So, and then of course the big thing is that there's another stabilizer called acoramidis, I can never talk, or Attruby that came out, and they're also doing a study in carriers to see whether or not they can prevent carriers from manifesting the disease. And then of course CRISPR gene technology, which is where you literally go in and you actually snip out the actual abnormal DNA. And what they do in this case is they're doing it in the liver cells because your liver makes 90% of the abnormal protein. And so it's, and that study went through, so has been first in human, which we call phase 1 studies, and so far is accumulating more patients. And so we're still waiting to see what will happen with that. So, and the reason why we like to highlight TTR is that it has the most gene therapies, the most therapies available for an inherited disease. And those gene therapies are being worked on in other diseases like PNP22 and other diseases. But those diseases are a little more complicated because you have to have the amount of gene regulation just right to work without causing bigger problems in the cell. So, so that was a lot of information. And I want to give time for Sean to talk about his story. So I'm going to stop there. I'm sure you guys will all have plenty of time for questions. And in case I skipped over something or missed something. But I just want to stop and pass along to Sean so he has plenty of time.
Thank you so much, Dr. Peltier. So next, I'd like to reintroduce Sean. As I mentioned earlier, Sean was diagnosed with hereditary amyloidosis back in 2019. I'd like to introduce actually him with his own words, which I think really capture both the challenges and hope that come with his diagnosis. So in Sean's own words, although this can be a devastating disease, I felt such a great sense of relief upon finally being diagnosed after a 7-year journey of worsening symptoms and multiple failed attempts to arrive at a diagnosis. I feel so fortunate that there are now novel medical treatments available that can slow down or halt the disease progression. I consider my case to be a success story. So I'll now turn it over to you, Sean, to share more about your journey, where you are today, and any of your hopes moving forward.
Well, thank you, and it's great to be here. So I have hereditary TTR amyloidosis. I've got the mutation, which was traditionally called T60. It's now called T60 or T80. And this mutation tends to be specific to people of Irish lineage. My name is Sean Riley, so you can kind of connect the dots on that one. So what I've got, I was diagnosed in February of 2019, but my symptoms started building in about 6 to 7 years prior to that. And as you'll hear from my story, I've got, I do have cardiac symptoms from the disease, but I also have polyneuropathy, both peripheral and autonomic symptoms. So when I was about 40 years old, 48, 49 years old, I started experiencing carpal tunnel in both of my hands. So at that point, I had bilateral carpal tunnel surgery. Incidentally, also at the same time, I developed a condition called trigger finger in 3 of my fingers and had surgery on those trigger fingers as well, on those fingers as well. I didn't think too much of it at the time because I was actually a fairly athletic person. I played ice hockey growing up, played into my adult years. I also lifted weights and whatnot. So I was a fairly physical person, did a lot of projects around the house and whatnot. So I just figured my carpal tunnel was just, a kind of chronic use of my hands over the years and was causing it. But little did I know at that time, and little did the surgeon know that what I was actually experiencing was the initial symptoms of the hereditary amyloidosis. A short time after that, I started experiencing numbness in my left foot and my left ankle. And I had previously had vascular surgery on that leg. So I figured that the numbness of my foot was due to, they had make one of the incisions down in my ankle bone. So I figured it was just nerve damage from the surgery. Again, the same theme, little did I know and little did the vascular surgeon know. What actually was happening was I was starting to experience the peripheral neuropathy building up, starting to build up in my left foot. And that has since progressed. I have peripheral neuropathy up through both of my legs, up past my hips, almost kind of into my abdomen. And I've got peripheral neuropathy in both hands, up my arms, up almost kind of past my elbows in each arm. So the disease there, you can see, has manifested itself with peripheral neuropathy. A short time after those initial neuropathic symptoms, I was sitting at home and I started feeling an uneasiness in my chest. I thought I was having a heart attack. I was brought to the hospital, the local hospital. I live in New Hampshire. So this all happened at a local hospital with no amyloidosis experts. So I was brought to the hospital. They did the workup to see if perhaps I had had a cardiac event, and all the blood work and whatnot came back negative. So they didn't see any signs of a cardiac event. So they sent me on my way. Same theme, little did I know and little did the people at the hospital know, but what I was actually experiencing was not necessarily a cardiac event. It was more of an acute bout of orthostatic hypotension, or a drop in my blood pressure, which we now know was caused by the neuropathic symptoms were now starting to affect my auto neuro system. So one of the things your auto neuro system does is regulate your body's blood pressure. So that function in my body is compromised. Fast forward about a year later after that, I started experiencing symptoms of acid reflux, symptoms of feeling full real early when I was eating meals, sometimes feeling nauseous, and also experiencing symptoms, alternating bouts of constipation and diarrhea. The local gastroenterologist at the hospital here in New Hampshire, they did an endoscopy and a colonoscopy, went in and couldn't really see anything wrong. So they kind of attributed it to perhaps I was experiencing the classic GERD or acid reflux disease. Same theme, little did we know at that time, but what was happening was I was experiencing amyloid buildup in my GI system tissues, and also it was affecting the nerves that control the processes in the GI system. Fast forward again another year or two, and this time I was actually at work, experienced the same uneasiness in my chest, brought to the hospital. Again, they did workups to see if I was having a heart attack. Came back again negative, no indications of a heart attack. This time they actually did a test, a angiogram on my heart, and it came back and it showed that my heart looked enlarged, but they kind of mistakenly attributed to that, and they called it, the doctor explained to me, it looked like I had an athlete's heart, a robust heart. What they were actually seeing was an enlargement of particularly my left ventricle of my heart due to the amyloid building up kind of in between the cells of my heart tissue. So that all happened about a 6 or 7 year period, all locally here where I live in New Hampshire. This is where my story takes a twist. In 2018, I decided to take an early retirement package for the company that I was working for. And at the same time, I was contacted by a professional recruiter who offered me a consulting job over in Abu Dhabi in the United Arab Emirates. So I decided to take that job offer and move a half a world away. And lo and behold, this decision helped save my life. I got over to Abu Dhabi in the middle of the summer in the Mideast, and on 2 occasions within a week of each other, I actually fainted. I passed out. So I was brought to the local clinic there, and they again did workups to see if I had some type of a cardiac event or whatnot. My first visit, they ended up attributing it to they thought maybe I was dehydrated from having moved over there in the middle of their summer. Sent me on my way, my return trip. The doctor had the presence of mind to say, well, maybe there was something more going on here cardiac wise. So they sent me to in Abu Dhabi. They actually have the famous Cleveland Clinic Hospital here in the United States. They have a center over in Abu Dhabi. So they sent me there to see actually a cardiologist. He sat me down. He was aware of all the symptoms that I was having, the neuropathy, the enlarged heart, the dizziness, the fainting, and he assembled a team of doctors. And ultimately, over about a 4-month period, they all collected their data and conversed with each other, and ended up performing a scan of my heart that showed that I had amyloid uptake in my heart. So that being said, the doctor explained to me that it looked like they couldn't confirm it, but it looked like I had this disease called amyloidosis, which they were not able to, they weren't experts with over there, and they didn't have the means to treat it. So they advised me to return back to the United States, I returned back and was seen at the Brigham and Women's Hospital in Boston, Massachusetts, where they confirmed my diagnosis. This was in March of 2019. I started in shortly thereafter on the drug that was talked about earlier, the RNA silencer, the drug patisiran, also a commercial name was Onpattro. That was an infusion. I got 75 of them, I believe. They were 3 weeks apart until I finally was swapped over to Vuitisiran, same type of drug made by also made by Alnylam, who's the sponsor of this conference that we're having here today. So that's what I'm on now, is the Vuitisiran, and it's what, 6-7 years after my diagnosis, and the medications have stopped. Excuse me, I'll stop my timer here. The medications, by all indications, have halted the progression of the disease. I still have all of these symptoms that they had progressed significantly by the time I had finally been diagnosed with the disease. So we do have to deal with all of these symptoms. Again, I have polyneuropathy, so peripheral neuropathy affecting my legs. I have pretty severe muscle wasting in my legs, so I do have some difficulty walking. I can walk on flat surfaces fine, but climbing stairs, it's not impossible, but almost impossible. It takes quite an effort. And I still deal with the auto-neuropathic symptoms, the bouts of orthostatic hypotension and the gastrointestinal symptoms. So that's my story, and I'll hand it back to our host, and I will participate in the Q&A period. So thank you for having me, and thank you for letting me talk.
Great. Thank you so much, Sean, for sharing your story, and Amanda Peltier too, Dr. Peltier, for coming back on. We're going to end today's program with some Q&A, which we've got about 15 minutes to do so. So I'm going to bring in some questions for both Dr. Peltier and also Sean. We received a lot of questions today, which is amazing. Thank you so much for submitting them. We also received questions at registration as well. So Dr. Peltier and Sean, I'm going to ask, sometimes the question will be directed towards one person, sometimes both, but as always, feel free to jump in even if the question is directed more for one of you. So I think actually, Sean, I'm going to start with a question for you just to kind of follow up with your story that you shared. So my question for you, Sean, is can you share a little bit what it was like navigating the healthcare system before you had answers, after receiving your diagnosis, just a little bit about that in the 6 or 7 years that you were kind of navigating these symptoms? What was that like?
Sure, it was actually very challenging. With this being a rarer disease, there aren't a lot of experts out there. And again, I had mentioned it in my story that most of my treatment was at a hospital here in New Hampshire, a local hospital, and to no fault of their own, they just weren't experts on the disease. All these symptoms were building in. I knew there was something wrong. But no one could put their finger on it. And in fact, at one point, it was even suggested to me that perhaps it was all in my head, which unfortunately I hear time and time again from not only from other amyloidosis patients, but to patients in the rare disease community as a whole, that they think, maybe perhaps there's nothing wrong with you, and you just kind of imagining things, but that wasn't the case. So yes, the path up to diagnosis was frustrating, to say the least.
Thank you for sharing, Sean. Yeah, and I think that is probably something that a lot of the viewers right now are kind of resonating with, is unfortunately something that they hear often. And I also want to point out too, on our FPN website, we do try to update our Find a Doctor section often. We try to add to that because we know it is very hard to find a neurologist or someone who is familiar with all these types of neuropathy, including hereditary neuropathies like amyloidosis and TTR amyloidosis. So
Yeah,
absolutely.
if I can just jump in again to add to that. So if there probably are people, in the audience here that are struggling to find an answer. And my advice to you is you're the expert of your own body. If you think something's wrong, it probably is. Are there cases of hypochondriacs that exist? Yes. But for large part, if you think there's something wrong with your body, there probably is, and be persistent and search for answers until you get one that satisfies you.
Absolutely, Sean. What a great note. Being a patient advocate and advocating for yourself is incredibly important. We at the foundation focus a lot on advocacy, and I hope that everyone here too is already hearing that message at the beginning of this wonderful Q&A we're going to have to advocate for yourself. So Dr. Amanda, and I'm sure too, you've had some conversations with a lot of patients too in your experience. You're kind of like want to hug you too in that aspect because you know kind of what they're dealing with and everything. But I don't know if you wanted to speak on anything about that Sean mentioned before I kind of bring another question to you, Dr. Peltier.
Yeah, so two things. One is you should always be, unafraid to ask for a second opinion. And frankly, I would be highly suspect if a doctor who absolutely refuses to, refer you on to somebody else. I mean, I still refer people to other institutions when either I feel like I've hit a wall and I'm not coming up with the answer, or sometimes if the patient asks, my only stipulation, as I jokingly tell people, is that they have to be smarter than me. And so I will give guidance on like, okay, I think you should see so-and-so or so-and-so or so-and-so, to make that referral. But I think it is important to be your own advocate. And I will have to say is that so many times, when we don't listen is where we end up making mistakes as doctors. So absolutely echo all that 100%. And then, and I think just the advantage of when you're subspecialized, it's easy for me to sometimes come up with a diagnosis because it's something I've seen on a regular basis where, somebody else who's never seen a patient with this particular disease or saw it and didn't know that they realized that they saw it, it's a lot harder because a lot of medicine is basically pattern recognition. And so if you don't know what the pattern is, you have no idea how to recognize it. So that's the other thing I would say. And amyloid itself is very challenging because it affects so many different organs and it affects so many different types of cells in the body that it has lots of different symptoms. And like I was alluding to earlier, that can be different in other people, in many people. And so, so it's just one of those things where, you have to be persistent.
Yeah, thank you, Dr. Peltier. I loved hearing kind of that. And I'm sure our listeners too love to hear that from a doctor's perspective too, from that patient advocacy piece. Thank you so much. All right, Dr. Peltier, a question for you. And as always, Sean, feel free to jump in. People in the chat and the questions box were asking a lot about any treatment options that are currently available for hereditary amyloidosis, TTR, that are emerging treatments or anything that you have seen recent come out of it. Some people mentioned gene therapy, IVIG, supplements, anything you want to mention, Dr. Peltier, would be great.
So one thing, IVIG is really good for autoimmune disorders. Rarely you can get a situation where you have an inherited disorder and an autoimmune disorder at the same time. That's pretty unlikely, but it does happen. We do see it. So we wouldn't typically think of IVIG for an inherited disorder. But on the other hand, what really happens in this disease is because it affects the motor fibers and the sensory fibers and causes a lot of similar symptoms. It's very common that people with this disease get confused for autoimmune diseases like CIDP or chronic inflammatory demyelinating polyneuropathy, which is why we just say CIDP. And so a lot of people end up on IVIG and then they don't respond. And that's when their doctors say, maybe I messed up and I have a different, it's not that. So that's number one. Number two, as far as other disorders, people have talked about supplements for a long time. People have looked at like different vitamins and the short answer is we just don't have a lot of data on a lot of them. And so So for pain, I'll often tell people to take alpha lipoic acid, which is a supplement studied in diabetic neuropathy, which is pretty benign, and 600 milligrams a day can sometimes help with pain. Some people have tried like L-carnitine and other supplements. The downside is that there's just not lots of good studies on them, so it's hard for us to be able to say, yes, this works, or no, this doesn't. And then you can always look up, as far as new treatments, clinicaltrials.gov, which is a website that the US government makes, that every company that's doing a study, every doctor that's doing a clinical trial has to register their trial on clinicaltrials.gov. So if you want to see like what's available, like being studied right now. So I can tell you, at least in this situation, the big things are, one is they're looking at antibodies that help the body pull out the amyloid abnormal protein that's already there to help the body get rid of it. So that's a really big one that's coming out, both for AL and for this. There's a third generation molecule that Alnylam is making. So first was patisiran, like Sean mentioned, that was an infusion every 3 weeks. Then they made vutrisiran, which was more targeted to the liver, a smaller dose that was injectable every 3 months. And now they're making a version that will be theoretically injected like once a year or even less. So that study is getting going. There's follow-up study, like I mentioned, with eplontersen for the heart cardiac issues. The CRISPR study is ongoing. And then one of the big things is I'm actually on the task force that was convened by the Peripheral Nerve Society and the European Association of Neurology to basically set up guidelines of how do we monitor people, and how do we create guidelines for how do we monitor carriers, like people, like family members of people who have the disease, to catch people, because right now our goal is to try to catch people right when they start showing symptoms, and to put them on treatment. We don't have a lot of data on when to start treatment. That's, because a lot of times people like Sean have been diagnosed way after the disease has been running its course for many years. So a lot of our goal is to try to get people to be diagnosed much earlier in the course of the disease. And then I think there was another question in there that I missed, so refresh my memory.
I think, well, Jean, it was kind of just overall, Dr. Peltier, with what you wanted to mention, emerging treatments. You talked about IVIG supplements, gene therapy. That was, I think, the only other thing that was in there, but thank you. Actually, I do have a question that just came in as kind of a follow-up question of that, Dr. Peltier. I think actually, Sean, you might be able to speak on this one as well. So what about those patients that are scared of some of these getting testing done, or kind of going out of their comfort zone and advocating for themselves to get this testing done? What would you kind of say to them? What advice do you have, Sean, but then also Dr. Peltier, from your professional standpoint, what can you share?
You're talking about testing to see if you've got the genetic mutation?
Yes, yes.
So my advice could be, because I've got family members that got tested, and my first advice is that knowledge is power. If you know you've got the mutation, even if the symptoms haven't started manifesting themselves, and there's a chance maybe they won't, but there's also a significant chance they will. Knowledge is power. On the caution end of it, I will say that before you get gene tested, you probably need to look at with some of these diseases and make sure that if you plan to have life insurance in place or whatnot, that you should get genetic counseling and make sure that you do that beforehand, because I know, like in my own instance, they can't disqualify you for medical insurance. That's illegal. But life insurance is a different story. So that's something to consider before you get genetically tested. But my overwhelming answer is knowledge is power. And if you know that you've got the mutation and you educate yourself and know what the early symptoms of the disease are, like the doctor said, the goal is to get diagnosed and get on treatment as early as possible before the disease starts progressing. So that would be my advice.
Thank you. Yes. Great.
Yeah, I just want to echo that because I actually have a family where the oldest brother got diagnosed first. Unfortunately, his sister already had heart problems, had atrial fibrillation from the disease, and had a stroke and had some neuropathy. But the youngest sister, who was many years younger than the older siblings, like we caught her because of testing early, like she just has a little bit of neuropathy, and she has done really well, has never developed the heart disease that her brother and sister have because we caught it a lot earlier. So that's the key, is to try to catch people before it gets, because we're not very good at undoing what's already been done, unfortunately, at the moment anyway. And so catching people early is our biggest goal. But I totally agree, Sean, the life insurance is a bit of a sticky issue. And so I often recommend people to wait and make sure that they have life insurance, talk to a genetic counselor, but the life insurance issue can be a little bit of an issue with this gene mutation and some others. And so, and that was exactly correct. Like, they can't technically discriminate against, medical history, but they can unfortunately deny you life insurance. So I usually recommend people to make sure that's squared away before they get tested. And you can get screened for the disease without officially getting tested if you're worried about, having a, affecting your life insurance, or if somebody doesn't have life insurance. So, so it's important. We have family discussions all the time, and, and talk to family members when we talk to, patients. So.
Yeah. And I think it's important to get to, again, on the theme of knowledge is power. So I've got two children. One of them has a mutation. They're both in their early 30s. It's good to know early on, because this disease can hit at any time. I know for the various mutations, they say there's an age range. Well, for example, I'm the youngest of 6 siblings. My symptoms started building in when I was in my late 40s. I've got a first cousin who just got diagnosed last year at the age of 78. We have the exact same mutation. Mine started manifesting itself in my 40s. He didn't notice anything until he was well into his 70s. So yeah, get tested if you know you have the mutation. Again, you can be on the lookout for this thing.
Great. Wonderful. Yes. Thank you both for that. I think that was a wonderful question too from our viewers that you guys answered as well. So we have time for about one more question, and I kind of like to always answer or ask this to our speakers that we have on here. And I think, the idea of knowledge is power, Sean, and that Amanda, you kind of Dr. Peltier, you kind of echoed, and this kind of might feed into your answer to this question. But this hour-long program, what is one thing or two things or a few takeaways that you want people to have from watching this, walking away from this program? What would you tell them to make sure that they gleaned from this conversation or this presentation?
I'll chirp in. I just want to reiterate what I've said, and I know we talked a lot about amyloidosis, but a lot of these neuropathic diseases, whether they be hereditary or non-hereditary, are still difficult to figure out. So I want to reiterate, you're the expert of your own body. Keep digging till you find an answer. And again, we just talked about it. If it is hereditary in nature, find out. If you know there's a family history, find out if you have the mutation, because again, knowledge is power. So those will be my two messages.
Thank you, Sean.
I guess my comment would be is that, I've been in this field now for over 20 years, and the number of genes that we have now compared to what we had or what we knew about when I was a resident and fellow in training is so much, is so huge. And it used to be the old school thought was, well, if you didn't have symptoms when you were a kid, then, well, it couldn't be genetic. And we definitely know that's not the case. You know, and like you were talking about how your cousin got diagnosed in their 70s. So I often advocate for genetic testing early and often kind of working up. I think one of the biggest things that people get frustrated with neuropathy is that we still have so many people who we don't know what the official cause is, and we call it idiopathic. And I'm hoping that over time that amount of people will shrink and shrink and shrink. But in the meantime, you know, talking to your doctor, getting testing, doing things to figure this out, you know, because in the long run it benefits everybody. And as we learn more about other diseases, we learn more about how to treat, you know, even the more common ones. So I would say, you know, and I would echo Sean's comment about being your own advocate. I think that's really, really crucial. So that would be the second, you know, the last thing. And I mean, there's so many things out there right now as far as, you know, treatments that are being studied and are close to coming to people, that it's exciting for me as a neurologist to hopefully have more options. The pain world, unfortunately, I'm still disappointed. We're still stuck with the same drugs we were basically 15 years ago. And it does not differentiate, like, you know, the type of neuropathy. It doesn't matter. Like, we're still using the old standards of gabapentin, pregabalin, Dilox, you know. So I would hope that, you know, in the future, you know, treating the symptoms of disease also continues to be important, and companies invest in it.
Wonderful. Thank you, Dr. Peltier. Well, again, thank you to both of you, Dr. Peltier, for your presentation, your expertise. We are incredibly lucky to have Dr. Peltier as a member of our board at the foundation. So she is a wonderful presenter to share with you guys today. And Sean, oh my goodness, thank you. You were the perfect, I think, speaker to follow up with Dr. Peltier. You guys did a wonderful job. We had so many questions come in from the audience. Thank you guys. So many great questions, answered as many as we could. So I want to thank you guys in the audience. I want to thank you, Dr. Peltier and Sean, and I also want to thank, again, Alnylam Pharmaceuticals for sponsoring this program and this event. If you enjoyed this program and want to continue supporting upcoming webinars like this, you can sign up for our newsletter to find out more about them. We've got another one in another month, next month. And if you want to ensure that we continue having them too, donate today. Anything you can helps. So we thank you guys. Have a great day.
Thank you for having me.
Thank you so much.